So now the panel can sit but speak at the same time. So I'm going to ask Dr. Lance Gordon, who's the Director for Infectious Diseases at the Global Health Programme of the Bill and Melinda Gates Foundation. And really, if you could give us a few words about the stance and position of the Gates Foundation with regard to this area.
Position with regard to the neglected infectious disease area, it's one of the 6 focused programs, what we call program strategy teams. So the NID group encompasses a portfolio of 17 disease targets. We started with a list of 47 when I joined 2.5 years ago, and winnowed it down to 17 with rank order priorities, and 6 of those were investing in understanding the disease better. 3 of them have been long-standing investments that have really completed their objectives, but we're still investing to facilitate the use of the interventions. For instance, we invested in studies to determine whether dog vaccination was an effective means of preventing human rabies. Was very effective. We're now investing in impact studies to inform policy and facilitate uptake in countries. Similarly, azithromycin treatment for trachoma, blinding trachoma. So it is very definitely a priority area, one that is having substantial impact, and I believe 4 of our disease targets are eradication, which we put a premium on.
Who do you support to do this? Or do you have any, do you just support whoever you think can get the job done?
Well, we actually have a pretty specific process. So when we target a disease area, generally the first thing that will bring a disease area to our attention is the relative global disease burden. And a second major feature is is there an opportunity for transformative change, to fundamentally change the disease landscape. If it meets those, we then do what we call a thorough landscaping. This will typically involve sponsoring conferences, bringing together advisory committees, consultants, and develop as thorough an understanding as possible. From that process, we set specific targets, a goal for what we want to accomplish regarding a particular disease. And then we map out what is called the theory of change. So this is the universe of things that would have to change in order to be able to achieve a goal for a particular disease, whether that be high-level control, regional elimination, or global eradication. And having mapped out that universe of change, then we go the next step, which is to look at what we call the theory of action. And that's when you really, the terminology is terrible, because that's when you get to not theory, but where are we going to take an active role? So it's those things that have to change that we believe fit our strategic position in the world, our abilities, and our goals. And those things that we will fund. How do we pick who to work with? That's a changing model. So historically in the Gates Foundation, everything was done through intermediates. We made no direct investments. We had no direct sponsorship in any form of private industry in the early years. Today we've adopted what we call a strength-based investing approach. So we look, in some cases it is a very capable PDP such as DNDi, who does a broad range of the work involved with identifying and developing a product, but in many other cases it's identifying who is the best entity to develop an animal model, what is the best investment to look at process development, pilot manufacture, clinical development. So those might be separate entities. It's who has the best capability. So it really varies quite a bit.
From my own perspective, I see the funders are very attracted by the transformative innovation, the quantum leap, the big question, the grand challenge. But who is going to support the boring but necessary small things, the change in a packaging, a revised tablet dosing, a new formulation? uninteresting, unexciting, potentially very important. Are you and the other funders really interested in this?
So the first observation is certainly true. We do look for the catalytic opportunity. We look for what can we invest in, what outcome would have the most impact on a disease. So we consider ourselves very broadly investors in impact these days. That's one of our mantras. But when it comes to what will have an important effect on a disease objective, we really take a very active role in funding many of those things. So a couple of examples that come to mind. One, we recently awarded some funding directly to Merck Serono to assist with their development of a pediatric formulation of praziquantel. So the current drug is a mixed enantiomer. It tastes nasty. It's a horse pill, contraindicated for children. So they committed to develop a pure L-enantiomer form that leaves behind the bad taste. It cuts the volume in half and would be targeted for pediatrics. So that's an area that we're taking a hand. We've invested in supporting studies to look at dose reduction in vaccines, certainly, and we're looking at some differences in drugs. We've invested in, I think we probably were, maybe sole funders in the vaccine vial monitors that are used broadly now to look at stability and temperature excursions. We invested in delivery technologies such as the Uniject technology. But there are many cases where it doesn't fit what we consider our strategic advantage. There are others that are better positioned to develop either a product or a change or a way to use something that really doesn't fit with the Gates Foundation. Nonetheless, if we identify it as part of the necessary landscape of change to accomplish an objective, we endeavor never to assume somebody else is going to handle it. So we will advocate. An example is the London Declaration, where one of the real objectives was to engage others who are better positioned to do things, to achieve the impact. We do today invest and support private industry. We do grants directly to individuals doing work, not just through the PDP, although that, when available, is a great asset.
If there are any questions, please come to the microphones. So just on the question of your overall strategy, how do you decide what's neglected and what's not?
We, as I said, we started with a compilation of the lists that different entities have. So we had the NIH list of what the NIH considered neglected infectious diseases. We had the World Health Organization. PLOS had a list. The Department of Defense also had a list. There were a number of lists. And when you tallied those up, there was 47 diseases that others had identified. We used 4 filters to select disease targets. The first was the relative burden of disease. Second was the opportunity for transformative change. So although guinea worm, hardly fit as one of the highest disease burdens in the world today, there is an opportunity to eradicate it for all time. So a great premium, and we targeted that. The third filter, which is an important one for us, is the opportunity for partnership. Now that means the opportunity to partner with, whether it's academic organizations, companies, PDPs, academics, because we hold no INDs, we have no wet labs, we don't do anything on our own. So we simply invest in, facilitate, and advocate for people to do those things. And we look for funding partners. So as an example, we took a direct stance that there needed to be funding to complete the job of eradicating guinea worm. That was a $70 million price tag to complete eradication of that disease. We put in 20 of the 70, but Bill Gates personally went around and twisted a lot of arms and spent a lot of time with people, as did our Policy and Advocacy Division. to round up the additional 50 million. Certainly the polio eradication effort follows the same model. Let's see, I think I'm forgetting one. So it was global burden of disease, opportunity for transformation, partnerships. Boy, mind lapse here.
It's a long way from Seattle.
It's a long way from Seattle. Time zones and a good lunch.
Well, anyway, Lance, thank you very much for that. You've got a chance to come back to him a bit later on.